To understand corticosteroids, we start with their origin, the adrenal cortex, where steroid hormones are naturally produced. While our bodies make them endogenously, we use synthetic versions, like prednisone and hydrocortisone, to mimic these hormones for their potent anti-inflammatory and immunosuppressive properties. A key clinical pearl to remember is that because these hormones are highly lipid-soluble, they can't just float freely in the blood. They require specialized carrier proteins, like transcortin, to travel through the bloodstream. So, how does the body decide when to release these hormones? It follows a three-step command chain called the HPA axis. It starts when the hypothalamus detects a stress stimulus and releases CRH. This signals the anterior pituitary to release ACTH, which finally travels to the adrenal cortex, triggering the release of cortisol and aldosterone into the blood. We generally classify corticosteroids into two main buckets. First, we have glucocorticoids, like cortisol, which primarily focus on metabolism and provide those powerful anti-inflammatory responses we rely on clinically. Then we have mineralocorticoids, like aldosterone. Their primary job is electrolyte and volume regulation. They promote sodium retention in the kidneys, and because water follows sodium, this drives fluid retention and elevates blood pressure. Cortisol is often called the stress hormone for a good reason. During high-stress situations, production can increase up to tenfold to maintain homeostasis. It triggers a metabolic shift called gluconeogenesis, where the liver is forced to create new glucose by pulling amino acids from muscle and triglycerides from fat. To ensure the brain has enough energy, it also creates an insulin blockade, stopping other tissues from using insulin so that glucose is prioritized for vital organs. At the cellular level, steroids work differently than most drugs. Because they are lipid-soluble, they bypass surface receptors and go straight to the nucleus to turn specific genes on or off. Their most important genetic roadblock is the inhibition of nuclear factor kappa B, NFKB. By stopping NFKB, the cell effectively shuts down the production of inflammatory cytokines. Looking at the bigger picture of inflammation, steroids provide a multi-level blockade. They inhibit both phospholipase A2 and COX enzymes. This is significant because it stops the production of prostaglandins, leukotrienes, and thromboxanes, the body's primary mediators of pain and inflammation. Because receptors for these hormones are everywhere, the effects are truly systemic. In the cardiovascular system, they increase heart contractility and blood pressure. Metabolically, they shift how the body handles carbs, proteins, and fats. They are also crucial for development, specifically for maturing a fetus's gut and lungs in utero. Finally, they are immunological suppressants, preventing white blood cells from migrating to sites of inflammation. Clinically, we use these for three main reasons: replacement therapy for conditions like Addison's disease, anti-inflammatory control for flares in rheumatoid arthritis or lupus, and immunosuppression to prevent organ transplant rejection or manage severe allergies. However, a major warning: while synthetic agents like methylprednisolone are highly effective, they must be used sparingly due to systemic risks. There is no free lunch with steroids. The higher the dose and the longer the duration, the greater the risk. Long-term use of high-dose steroids shifts the body from a state of managed homeostasis into profound multi-organ dysfunction. Let's break down those risks by organ system. In the cardiovascular system, patients risk premature atherosclerosis and dangerous arrhythmias like VTAC. Renally, the cross-reactivity with mineralocorticoid receptors leads to severe salt and fluid retention, causing edema. In the gastrointestinal tract, steroids reduce the protective stomach lining while increasing acid, risking severe ulceration, which may manifest as black, tarry stools. The neuroocular effects are also significant. High-dose IV bursts can trigger acute psychosis, including hallucinations. Long-term, patients may suffer from memory degradation and mood disorders. For the eyes, there is a high risk of cataracts, causing glares or halos, and exophthalmos, which is the outward bulging of the eyes. Steroids are particularly hard on the bones. They inhibit bone-building cells while stimulating bone-breaking cells, leading to severe osteoporosis. Long-term use can induce Cushing's syndrome, characterized by central obesity and purple stretch marks, striae. Finally, the profound immunosuppression leaves patients highly susceptible to opportunistic infections. To help you remember all these side effects for your exams or clinical practice, use the mnemonic Corticosteroids. It covers everything from Cushing's and osteoporosis to immunosuppression and stomach ulcers. Thank you for watching this deep dive into corticosteroids. If you found this helpful, please like, share, and subscribe to CleanMedKE for more medical essentials. We'll see you in the next one.